Now I'm going to demonstrate my vital signs OSCE. I have Emily here to help me. Hi Emily, I'm Zach, I'm a paramedic student. Do you mind if I take your heart rate and blood pressure?
Yep, that's fine.
Okay, so I'm going to take her respiratory rate at the same time as taking her heart rate. This will keep her breathing normally. So I'm just going to touch your wrist, it's alright. Locate the radial pulse. Yeah. We're going to take it for 15 seconds and multiply by 4. Thank you. 4 breaths in 15 seconds, so 16 breaths a minute. We have 18 heartbeats in 15 seconds, which is times 4, 76 beats per minute. We're now going to go on to blood pressure. Emily, do you mind if I put this on your upper arm?
That's alright.
Thank you. So we want to make sure we get any restrictive clothing out of the way. So we're going to locate her brachial pulse. Apply the stethoscope. We're going to pump up until we can't no longer hear her radial pulse. Okay. We're now going to release the valve. First sound we hear is her systolic, and when we can no longer hear her blood, where it's at diastolic. Okay, so we got a heart rate of 120/90, which is normal. Hypertensive is above 140, hypotensive being below 80. With our pulse, we also want to make sure it's strong and regular. Same with the breathing, make sure it's regular breaths. Thanks.
We're now going to demonstrate lung auscultation with Emily. So first want to make sure I gain consent, and then we're going to instruct her to take breaths while I listen. Emily, do you mind if I auscultate your lungs? I'm just going to be listening to your chest. Okay, so just excuse me, do you mind if I can do this? Okay, I'm just going to apply this to your skin, and can I get you to take one deep breath through your nose and out through your mouth? Okay, same on the other side. In. Yeah. Mind if I untuck your shirt?
Yeah, that's all right.
So I'm just going to listen to your lower quadrant.
Yeah.
Deep breath in. Out. And out. Same on the other side. Deep breath in. And out. Okay, I'm going to do the same on your back, if that's okay.
Yeah.
Alright. Deep breath in. And out. Deep breath in. And out. Deep breath in. Deep breath in. Deep breath in. And out. Thank you very much. So we're listening for any crackling or wheezing which isn't present, or any other irregularities that you can hear through a breath. Now going to demonstrate my suction OSCE. So the first thing we want to do with a suction unit is perform a test. Do this by holding the test and turning to maximal power. When the lag goes to second, we can obstruct the flow. We want to make sure that we reach full power before releasing. And we'll go to the 4th dot, meaning we've completed the test. And then turn it off and turn it on, and it's ready for suction. So we're going to use this on patients who have vomited to clear their mouth of vomiters. We need to first locate the patient laterally. We're going to use a rigid catheter. Turn the suction on. We're going to insert only as far as we can see, and then only suction on the way out. We want to make sure we're not suctioning for more than 10 seconds. So again, in, closed, suction out. Complications can include soft tissue damage, vomiting, choking, and induction of bradycardia from stimulation of the vagal nerve. We want to make sure that we don't use a rigid catheter in a moving vehicle, as any sudden jolts can cause quite severe soft tissue damage. When we're finished, we can clear the lines using water and then clear the holding tank. Now I'm going to demonstrate my OPA and NPA Osce. We're going to use both of these to ensure the airways are kept clear during resus and ventilation. So we want to size them appropriately. We're going to size from the angle of the mouth, from the end of the mouth to the angle of the jaw. Slightly too large, so we'll check a size smaller, and it's a good size. But we want to insert them initially upside down before twisting and rotating them and inserting the rest of the way. We now have the tongue kept out of the way. We don't want to apply a OPA in a moving vehicle or when significant head trauma is present. These can also cause some small soft tissue damage. For an NPA, we're going to measure from the nostril to the angle of the jaw. So it's looking like a good fit. We'll check one size up. Yeah, it's too large. So we're going to make sure we lubricate this with a human patient. We're going to insert straight in. If we have any resistance, we're going to either twist, or worst case we can use the alternative nostril. So we now have an open airway between the nostril and the throat, and same with the mouth. We don't want to use NPAs if nasal polyps are present or if there are basal skull fractures, as this can cause further complications. I'm now going to show my oxygen administration Osce. Here we have a canister of oxygen, so we're going to make sure it is oxygen. It's a white tank, sometimes has a black neck, and we'll have a tag on it that says oxygen. We'll also have a neck tag showing whether it's full, in use, or empty. On the pillar, it has 3 holes which correspond to the 3 prongs on the oxygen regulator. To attach this regulator, we line up the prongs with the holes, slide it over the pillar, and tighten. You can then open the pillar valve, showing which registers gas pressure on the gauge. We're going to administer oxygen via nasal prongs, which can deliver approximately 20 to 40% of oxygen to a patient using a flow rate of 2 to 4 liters. We can attach the tubing to the nipple and then turn up to 2 liters per minute, securing the nasal prongs under the ears and tightening under the neck to ensure they stay on the patient. We then, to remove and pack up the oxygen, first take the prongs from the patient before turning off the flow, and then remove the tubing, close the pillar valve, and bleed before removing the regulator. Oxygen can be used for patients with a reduced SpO2 rating and has very small contraindications. Thank you. And also an NPA, which you can size. We want to make sure we lubricate this with a human patient. We're going to attach to oxygen using a high flow of 10 to 15 liters per minute to ensure our reservoir bag remains full. We're going to use an OK grip, grabbing underneath the chin, ensuring head-chin tilt, lift, and ventilating. We want to check for chest rise, and be ventilating at a rate of about once every 5 to 8 seconds. We also want to keep an eye on the abdominal region, as inflation here can show that air is passing into the stomach. We're just going to keep delivering breaths until we are no longer required to do so.
now going to demonstrate hemorrhage control with the dressing. So our patients told us that they have a cut to their forearm, so we want to expose the wound, visually inspect it. If it requires cleaning, if it's full of gravel, we want to make sure we get that out. We can use saline to do so. We then want to take a dressing and make it as small as possible to cover the entire wound, and we want to irrigate that. It helps keep it non-stick. We then want to apply direct pressure to the wound. If the patient's conscious, we can get them to hold the dressing while we prepare our bandage. So then using the bandage, we're going to apply increased pressure. More pressure can be applied by putting twists through the bandage. We can then tape this or tie this off when we're happy that we've applied enough pressure. With wounds, we want to make sure that, with bandaging, we want to make sure that we always keep the extremity of the limb uncovered, so we can feel for temperature, visually inspect for colour, and also check for capillary refill. If the wound does bleed through the dressing, it's a sign that there's not enough pressure, so we can apply a second dressing on top of the first and re-wrap with more pressure on the bandage. If that still bleeds through, then you may want to apply a tourniquet. There's a large laceration to his brachial artery around the elbow. So we're going to place the tourniquet over his arm and tighten at least 10 centimeters proximal to the wound. I'm going to tighten the windlass and secure when bleeding is stopped. You can also check for a radial pulse until a radial pulse disappears. We want to make sure we document the time on the tourniquet, as this is rather important. If bleeding resumes, which we can tell as we'll keep the wound cleared, if bleeding resumes, we can apply a second tourniquet proximal to the first. Thank you. Now I'm going to demonstrate my splinting Osce. We're going to start by explaining our assessment to our patient and gaining their consent. Hi sir, I'm with the ambulance. You've told us you have a sore foot. Do you mind if I have a look and proceed to potentially splint it? On their verbal consent, we can then expose the injury. So, looking at the right ankle here, where the chief complaint is, we're going to use the plus disc acronym along with their history. So we're going to ask questions to do with their pain, whether they've experienced any loss of movement. We're going to look to see if it looks unnatural
or if there's swelling. We're also going to look for deformity and irregularity, any shortening, if there's crepsis, or if the patient is in shock. So we can, from your history and what we can see, we suspect you have a Potts fracture of the ankle. If you don't mind, we're going to go ahead and splint it after we give you some pain relief. Before we move the limb, we want to make sure there's adequate pain management, so we're going to see if we can give this patient methoxy by checking the contraindications. So, have you had methoxy in the last week? Do you know if you have any renal impairment? Do you have a history or family history of malignant hypothermia? And you're able to obey my commands. So I'm going to give you 3 milliliters of methoxy for now. We can give a second dose of 3 milliliters later on if we need to. So sir, I'm now going to coach you how to take this. If you can please just inhale through the whistle end and exhale out through the same end, that'd be great. So if you can just take a few deep breaths. We also want to do a neurological and cardiovascular assessment, so he's conscious and breathing with a GCS of 15 currently. Alright, pain management is working, so we're going to go ahead and splint his ankle. We're going to use towels and cardboard and bandages to do so. So you're going to have the towel. So I'm just going to lift your ankle and support it with a towel. We want to wrap this nicely around his ankle for support. Put it in the cardboard. You can now bandage this. increase support. This will help keep it immobile during transport, as we don't want further damage to occur through rotation of the limb. So just keep using that pain relief, please. Okay. So we're now ready to transport to hospital. We want to make sure, we want to do a neurological and cardiovascular assessment now. Make sure nothing's degraded, that his condition hasn't deteriorated. So he's still breathing, he's still responsive, still has a GCS of 15, so that's good. Okay. Demonstrate my C-collar OSCE. So we're going to first use the nexus criteria to ensure we have a injury which warrants a C-collar. We're looking for altered GCS, impaired neurological focus, midline spinal tenderness, intoxication, or distracting injuries. So sir, can you just tell me, do you mind if I touch you to perform this assessment? Upon verbal consent, we can then go ahead. I'm just going to touch the back of your neck. Is this sore? We can feel some slight irregularity in the neck, and he's told us that it's painful. So I'm going to have my offsider secure his head in this fashion where it doesn't obstruct the neck, but keeps his head in a neutral alignment. While my offsider does that, I'm going to measure for my C-collar. I'm going to use fingers from his clavicle up to the jaw, and then do that on the collar. You can then adjust if necessary using the clips. I'm going to move it to no neck, clip it in place. We can help pre-form it before applying. So I'm just going to place this collar on your neck, if you don't mind. Whilst this is not full immobilization, so we're going to have someone continue to hold their head, keeping it in neutral alignment until we can either apply head blocks and full body immobilization, or get them to hospital and have the C-spine cleared. Next, I'm going to be demonstrating my monitor and ECG OSCE using the Philips MRX. We're going to first check there's batteries present, which can be found on the back. These can be replaced using these clips on the side. Now I'm going to turn it to monitor mode. While it starts up, we're going to get our shock cable out from this side. Preemptively, we're going to go to menu, down to other, and begin the operational check. So we're just going to acknowledge that we're leaving the monitor mode, and it's going to start the check. We can apply the test load, as it's going to prompt us to do so soon, and turn the therapy knob to 150 joules.
Soon it's going to ask us to charge and deliver a test shock. So until then we're just going to pay attention to any prompts. Press the charge button. Shock, delivering shock.
Shock delivered.
We're just going to acknowledge that we've heard shock delivered. It's going to continue running the rest of the test. While that happens, we'll go through the rest of the pack. On this side we have our diagnostics. So we have our non-invasive blood pressure cuff. We have our end-tidal CO2 present. We have our 3-lead, which we're going to be demonstrating on Megan soon. We also have our SpO2 and heart rate probe, SATS probe, yeah. It's still proceeding. In the back pocket we have our 12 leads, we have a razor and aspirin, we have GTN spray, and we have ECG dots. We're going to take out 3 now and attach them to save time later. Okay. Still running the test, so we'll tidy up our diagnostics. Still going. Okay, Megan, I might just apply these dots before this test runs out to save some time. Do you mind if I put these dots on your chest?
Yeah, that's fine.
Okay. So I'm looking at the labels on the leads. We're going to start with left arm, so I'm just going to apply 2 at the top and 1 on your hip. So So if you don't mind, just applying this just below the clavicle on her left side. We're now going to do the right, which is the white one. Again, just above the clavicle. And applying this on her hip. You don't mind if I lift up your shirt? That's fine. And just applying that there. Alright, operational check is passed. So we're going to print that using the print button. Make sure the printer works. Which maybe. Okay, we're now going to exit the operational check, return it to monitor mode. We're going to leave our test shock on. Okay, so we're going to turn off the alarm, and we're going to change the leads to display our, our 3 lead on the first wave. We can change the size using the menu, so we can go up to 4 times. We want to return this usually to the standard 1 times, as it can affect how you read a 3 lead. We're also going to change the volume of the alarm to very loud, so this can be used in a moving vehicle so that you can continue to monitor even if you're up front. We've got the non-invasive blood pressure cuff button here that we can use to take a non-invasive blood pressure. So we'll also deliver we'll go up to 70 joules and charge and deliver a test shock. We'll also demonstrate how to dump a shock, so we're charged, and we can disarm a shock using the disarm button. It will prompt us to let us know that that's occurred. Okay, so we can see that the movement is causing the 3 lead to change, but we're finished with that. Thank you very much, Megan. So we're going to turn it to off. We can also use this defibrillator in AED mode.
Analyzing heart rhythm. Do not
Using the
touch
therapy
the
mode,
patient.
in case our patient goes into cardiac arrest. I'm going to be demonstrating our resus. We're wearing appropriate PPE, goggles, gloves, shoes. We have appropriate equipment, kit bag, suction kit, oxygen, and AED. We're going to be following the acronym Doctors ABCD to potentially save this man's life. We've deemed it a non-futile resuscitation, so we're going to attempt to resus. Anthony and I will be attending. Anthony's going to be my offsider. He's going to be operating the kit while I deliver oxygen and defibrillation. Our dangers could potentially be environmental hazards, traffic, fuel, electricity, or people that may harm us. If these dangers are unmanageable, we're going to move the patient to a safe location. Okay, going in with R, response. Excuse me, sir, I'm Zach, I'm a paramedic. Can you hear me? No response, trapezoid, no response to pain. I'm going to look inside the airways. No obstruction to airway. Look, listen, and feel for breathing for 10 seconds. No signs of life. Anthony, can I get you on compressions? Radio for assistance. Comms, this is AUT1. Patient confirmed, confirming R49, requesting R50 or ICP backup. Setting up the AED. We're going to place the pads as denoted on the pads. One down the left side, and on the right upper torso. Keep going.
Analyzing heart rhythm. Do not touch the patient.
I'll get you back on compressions shortly.
Shock advised.
Can you get back on compressions while it charges?
Stay clear of
Keep going.
Deliver
Clear.
shock now. Press shock deliver.
Deliver it back on.
Pause.
Keep going until I tell you.
Start CPR.
Just going to set up the oxygen. We're going to use a flow rate of 15 litres per minute. We're going to use an OPA to make sure size it correctly to ensure that the airways stay open. Alright, just deliver another 10 and then count down.
5, 4, 3, 2, 1.
Chest rise. Chest rise. We're going to be delivering compressions at a rate of 100 to 120 per minute.
21, 22, 26, 27, 30.
Chest rise. Chest rise. Our compression should be aimed to be 5 centimeters deep. This helps ensure adequate blood supply throughout the body. Chest rise. Chest rise. Great work, Anthony. So when the defib talks to us again, we're going to swap positions. So I'm using a C grip for oxygen administration. This grip ensures that the airway stays open, that the mask stays attached to the face, so enough air can enter the lungs. Chest rise. Chest rise.
Stop CPR.
Okay, we'll swap spots.
Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause. If needed, start CPR.
16, 17, 18, 19, 29, 30. 5, 6, 7, 14, 27, 28, 29, 30. Just rise. 7, 8, 9, 10, 11, 12. 21, 22, 23, 24, 26, 27, 28, 29, 30. We'll continue resuscitation until either ROSC or we hand over to an ICP paramedic.